So, respected Chair, a very good morning. A very warm welcome to everybody to this APO AIOS conference. I'll be speaking on cataract surgery in patients with potential risk of post-op diabetic macular edema. We are doing cataract surgeries day in and day out, but there are some patients who we are dealing with who have sometimes uncontrolled diabetes or are long-standing diabetics, and those are the patients who are potentially at risk of DME. And we will be talking about those patients. I have no financial interest in any of the products. So you're doing a perfect surgery, you are very happy with your axis, you have a little cortical matter left. And these are the patients who are diabetics, you have controlled them, they are long-standing diabetics. And when everything is going normal, you don't have to worry about anything. But if something goes wrong and then there is a cascade which starts and complications go on becoming more and more deeper, and that is when it becomes difficult to manage things. So in this, you will see that there's a little cortical matter remaining, and if you see carefully in the center, you will see a speck of cataract remaining over there. So first we remove this remnant cortical matter, and now I am tempted to go and chase the little speck which is there in the center, and I'm trying to polish it, and there is where I hit. Can you see that posterior capsule tear? So this is what I wanted to show. So we are diabetics more prone to endothelial cell loss during phacoemulsification in more than normal subjects? And the answer is yes. Is the posterior capsule more fragile in long-standing diabetics? We still have to know. Are diabetics more prone to diabetic macular edema post-cataract surgery as compared to non-diabetics? Yes. The progression or recurrence of DME following prompt cataract surgery is a profound disappointment both for the surgeon and the patients. Patients with diabetic retinopathy are more predisposed to poorer post-operative visual acuity and are at a higher risk of complications after cataract surgery when compared with those with diabetic retinopathy. The risk is even higher in the presence of pre-existing diabetic retinopathy. The risk of developing post-operative DME is directly proportional to the severity of diabetic retinopathy. So in patients who you see diabetic retinopathy and you are planning to do cataract surgery for some reason, if the visualization is not good, if you are planning to do it before, then you keep in mind that there is a higher chances of DME. In diabetic patients who underwent cataract surgery, macular edema can result either from pseudophakic CME or from a pre-existing DME itself. Both entities are characterized by fluid accumulation in the retinal tissues in macular region, but these two diseases have to be distinguished. There's minimal diabetic retinopathy, and the absence of aggregates point more towards pseudophakic CME. DME often presents with an underlying diabetic retinopathy, exudates, and macular edema. The risks are significantly higher than for patients without concurrent or previous history of DME at the time of surgery. The management of pre-existing DME with visually significant cataract is a clinical conundrum because you are in a fix of which one to do first. Deferring cataract surgery until DME is adequately treated may not always be an ideal situation like we have been taught conventionally, because of prolonged visual impairment and maturation of cataract jeopardizing surgical safety and monitoring of diabetic retinopathy. However, with patients with pre-existing diabetic retinopathy, if the fundal view is good, then you can go ahead and do the management of diabetic macular edema first and then do the cataract surgery. In these uncontrolled diabetics, you must get HbA1c also done. It's known to be a significant risk for diabetic retinopathy. And the management of concurrent DME at the time of cataract surgery is much more challenging because of DME is unlikely to resolve spontaneously. I will skip these and go to the management directly. There are anti-inflammatory drugs which we must use in these diabetic patients before we are doing cataract surgery, regardless of whether you are anticipating DME or not. Your use of topical corticosteroids also we are using to reduce the inflammation, but it also helps along with NSAIDs. And in some cases, as we know, we need to do lasers also. NSAIDs are associated with side effects such as transient burning sensation and epithelial corneal defects, so it's advisable not to tell them to use for long period of time, even after the cataract surgery after 3 weeks to 4 weeks. Although the mechanism of action of topical steroid is similar to those of NSAID, a topical steroid is more inferior in prevention of pseudophakic CME, probably due to its lower penetration in the eye, and there are more side effects like increasing the intraocular pressure. The addition of a topical steroid did not have significant effect on the lowering the chance of post-operative DME, but should be prescribed to suppress other forms of intraocular inflammation. We also know that intravitreal injections are there, which we are using regularly. When you see a DME, it's good to manage it 14 days earlier and then do a follow-up, see the macular thickness and then plan your cataract surgery. See the macular thickness on OCT. Intravitreal injections of corticosteroid and anti-VEGF as first line of therapy have demonstrated safety and efficacy to treat diabetic macular edema. These are the different anti-VEGF injections, which I won't go into detail. This is Ozurdex, and we are also using lasers. Now, when you have complications like prolonged surgical time, excessive manipulation, excessive use of phaco energy, or if you have a posterior capsule tear, as I showed in the beginning, then the management becomes even more difficult. If you have a non-intact posterior capsule, if there is prolapse of the vitreous, there is iris chaffing, if there is retained lens matter, if there is prolonged operation time, then the risk becomes even more. So thank you very much for your patient hearing.
Very nice, excellent. Dr. Ikeda, would you like to ask some clarification?
I mean, we all know that we have to be very careful in diabetics, and I think one thing that really helps is doing a preoperative OCT for all the diabetics that we are operating, so that sometimes we might miss macular edema when we are doing a fundus examination. So if we have subclinical macular edema or something that we have missed because of the cataract, then preoperative OCT and documenting it really helps in these patients. Yes. Thank you.
Thank you very much.
Excellent, Dr. Satyajit Sinha, as always.
Sir, a query is there.
Yes.
If a patient is having a pre-existing DME and is subjected for cataract surgery, so would you like to dry up the macula first by giving preoperative anti-VEGFs, or would you take up a thing like Ozurdex along with cataract surgery? What's your take?
So there are two parts of it. One is the management part per se, what you are asking, and the other part is good visualization. Depending upon which grade of cataract you are dealing with when you are anticipating diabetic macular edema. If you have good visualization, it's better to treat and manage the DME first and then go ahead after 2 weeks and 1 month follow-up and then do the cataract surgery. And but if you do not have proper visualization, if the vitreoretinal surgeon finds it difficult to manage, then first do the cataract surgery and then manage the DME.
An Ozurdex along with phaco should work in that scenario?
Some surgeons are doing that. They are giving Ozurdex at the same time on the same table during the surgery also.
Thank you.
I think doing, as you have explained, doing HbA1c is very, very important in these cases, because sometimes patients comes to us, he says he's okay with the blood sugar levels for the last few days, 3, 4, 5 days, and HbA1c is 9.5 or something. These are the cases which land us into trouble, and he has rightly mentioned.